Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, I am going to show a case of type 3 PPC which is being managed by Patwardhan's sideways trenching technique. And before I start the surgical video, I want to give you a brief introduction about the OCT based types of posterior polar cataract. There is a very good paper by Professor J.S. Titial and his colleagues showing different types of OCT in PPC. So in type 1 PPC, there is an intact PC and there is some clearance between PC and the opacity. In type 2, there is an intact PC in the periphery, but in the central part, the PC is not very clear. And in type 3, the opacity is more dense, there is extensive shadowing, and the PC cannot be delineated at all. So this is type 1 PPC where you can see some clearance zone and you can see the intact PC throughout in all scans. In type 2, the density is little bit more and you can see that in the central part, you may not be able to detect the PC in all scans. So there will be some patchiness in the appearance of the PC. In type 3, you can see it's a dense opacity and there might be some mild bulge there, but you are not able to see the PC at all. And I have described type 4 PPC where there is already a dehiscence of posterior capsule and you can see that the nucleus matter or the lens matter has already traveled in the Berger space, which means the PC is already open. So you can see now on OCT, this is a type 3 PPC because you cannot see the central posterior capsule at all and the density is there in the central part and you can see the dense central posterior plaque there. This is a 81-year-old male and he gave a history that probably 35 years back he had shown to ophthalmologist and he was advised against the surgery, probably because it was a posterior polar cataract and he was explained about the risk. So he left it as it is and now he has presented with further loss of vision. So I want to take care of this cataract now. So the first thing I am going to do is do a oval rhexis. This technique is described by Dr. Kiranjit Singh, and this oval rhexis helps one way. It has a longer diameter on one side, almost up to 5.5 mm. So if you need to remove the nucleus, it's easier with that wider diameter. But on the perpendicular to that, we have a smaller diameter which is around 4.5. So in case you have to do optic capture, you can do it quite easily. Also in the subincial area, because on that side I generally keep the longer diameter of this oval rhexis, you can approach the epinucleus and release the epinucleus easily. Mechanical dissection, which I am doing now with a flat blunt tip, you can see the tip is very curved, it's blunt, so I can go till the equator using this iris repositor and I am basically releasing all the epinucleus from the capsule. So I am trying to go as closer to the capsule as possible. And this is a technique I am going to use, which is published by me in 2024. It's called sideways trenching technique. And the basic idea or concept behind this is that in denser cataract like this one with a posterior polar element, we should not rotate the nucleus, and with these denser cataracts it's difficult to carry out nucleus removal without rotation. So what I'm going to do is first make a deep trench right in the center and then I'm going to go sideways. So I'm using here Ozil platform using Centurion FECO and I'm going sideways here so that I have the cross kind of a trench which we normally do in the 4-quadrant technique but without any rotation of the nucleus. So that is what I am going to achieve now, and once I have proper depth of the trench on all 4 sides, I'm going to gently separate these four quadrants, but I generally try to keep them attached at the center where the posterior plaque is. So I'm going to separate them more peripherally and keep the center as far as possible attached, because if you try to overzealously attempt the separation at the center, sometimes it itself might open the posterior capsule completely. So that is something which I want to avoid. Once the divisions are made, I'm gently trying to separate them, and then I will be doing quadrant removal. Just watch the IOP which I am maintaining just at 20, and this is the key for managing these kind of type 3 and type 4 posteropolar cataracts where posterior capsule is likely to be dehiscent. When you keep the intraocular pressure low, anterior chamber is maintained without deepening of the anterior chamber, and that is really crucial in these cases. So, and also I am going to keep low flow rate. You can see I have kept a flow rate of just 30. So in usual cases I keep flow rate of 50, 55. So it's very fast, but in these cases I want to keep it low, around 30, so that I'm doing little slow motion emulsification here, because sometimes if we keep very high flow rate, what happens is that when you remove the one piece, suddenly there is a gush of fluid inside the eye, and which might open the posterior capsule. So here the two quadrants which are remaining in the subincisional area, I have refilled the chamber with viscoelastic, and just watch that I always do aqueous OVD exchange when I take out the probe. So now without rotation of the these quadrants, I am pulling them out in the center, and now I am refilling the bag using Hylucoat, which is similar to Viscoat. So it's a heavy dispersive OVD which will keep the posterior capsule back, avoiding rupture. And using the same low flow parameters, I am going to remove this quadrant. It will be little anterior phacoemulsification, but it is not going to damage the endothelium because I am using very low phaco energy here, and also I am coating the endothelium continuously with dispersive agent. Now the last piece is there, and you have to be very careful to pull it up, and many times you have to be very careful to fill the bag repeatedly using dispersive OVD. So you should not have shallowing of the anterior chamber. At the same time, you should also avoid excessive deepening of the anterior chamber as well. So I'll push some OVD here below the nucleus, and once that is done, I will just pull it up, that last quadrant in the anterior chamber. Again, use the low flow dynamics. Posterior polar cataract is about maintaining all these principles all throughout the surgery, right from the beginning till the end, because even if you miss these principles even for a split second, you will have a split posterior capsule, and you may have further complications like vitreous prolapse or nucleus drop as well. So this is the last piece which I am taking out. Again, you can see the IOP maintain is just 20, so there is no bowing down of the posterior capsule. Now you can see the posterior capsule there, it's very thin right at the center, and I've removed all the quadrants. Now I'll be doing the OVD BSS exchange here, and this is something you must learn in your cases so that you can do it very easily in these kind of demanding cases. During cortex removal as well, I'll be keeping little low flow. I don't want any gush of fluid towards the posterior capsule, so it will be removed very carefully, keeping a watch on the posterior capsule. There will be some opacities on posterior capsule in these cases, but we must avoid the temptation to go near the posterior capsule, because though at present it looks quite intact, these are very fragile capsules, and even a minor tuck on that will cause a posterior capsule opening. So just watch the OCT based classification again, and I have given the fourth type of PPC also, which is with the pre-existing dehiscence. I have shown this video in my on my YouTube channel previously also, with some cases where the posterior capsule was already dehiscent. You could see the cortex and the lens matter in the Berger space even when we are beginning. So if we take all the precautions, what we can do is we can keep the antihyaloid intact, and in most of the cases even we can keep the posterior capsule intact. If we have posterior capsule intact, we can place the IOL in the bag easily. Even if there is a PC rupture, if we can maintain the antihyaloid, that also helps in placing the IOL in the bag. So avoiding antihyaloid rupture is the second thing which we want to look for. So if we can save the posterior capsule, it is good. If the PC is already open, like in type 4 PPC, we can still maintain the antihyaloid and place the IOL in the bag. So this patient did really well in the post-operative period. The vision improved, and I was glad that I could finish the surgery without any PC rupture or any other complication. So when you watch the surgery again, you can find that each and every time I'm using the same principles. Avoid excessive deepening or shallowing of the anterior chamber, avoiding hydrodissection. I use the Patwardhan's sideways trenching method in this case. This is really useful technique for denser cataracts like these ones where patient waited for very long time. Most often, of course, we get post-polar cataract in younger patient because they present early, and in those cases, you can just do layer by layer method of removal of the lens matter. Thank you so much for watching.